Okay, well, good afternoon, everyone, and welcome to Paediatric Teaching. Thanks for coming online, those who have, and we'll try to record this session so people can watch it later on. I wanted to talk today about soil-transmitted helminth infections in children, partly because sometimes they're quite confusing because there's a variety of different types, but they all produce very common symptoms and signs, and they're symptoms and signs that we see every day, clinical features that we see every day. And so, but we often don't think, could helminth infections cause these symptoms and signs? And often they don't, of course. There's alternative explanations, and often helminth infections are completely asymptomatic, but you need to know what the general clinical features are of helminth infections and how to recognize them in children. So let's talk about that, mostly because they're just so common in PNG and in countries throughout the world, soil-transmitted helminth infections in children. I'll just start by saying that these infections, soil-transmitted helminths, are one of a list of about 20 different diseases that the World Health Organization says are neglected tropical diseases. And they're neglected because they're common in the lowest income areas. They're common among people who live in relative poverty, and there's often not very good prevention and treatment strategies for these diseases. So I've put in green the neglected tropical diseases, the NTDs, that are found in Papua New Guinea, and there's many. Of course, there's other ones, onchocerciasis, that's found in Africa only and other places, but not in PNG. But I put the ones that are found in PNG. But soil-transmitted helminth infections are by far the most common infections or infestations among the neglected tropical diseases that are found in PNG. We hear a lot about snakebite, but actually soil-transmitted helminth infections are much more common, of course, than snakebite in terms of the population, the people that they affect. Now, I wanted to start by showing a few slides that just summarize everything you need to know. And so just 3 slides that summarize everything you need to know. And the most important thing, I think, is to identify the symptoms and signs of helminth infections or helminth infestations. And the reason I made this slide up is because the symptoms and signs are just so common. You know, we see so many children with failure to thrive or severe malnutrition or iron deficiency anemia, or who have development, cognitive or intellectual development, and many children with edema. So they're general symptoms and signs of helminth infections. And then there's many that relate to the gastrointestinal tract, of course. They can cause diarrhoea. They often cause abdominal pain or abdominal distension. They may cause a bowel obstruction, either because of intussusception or because of mechanical bowel obstruction with the worms themselves. They may block up the bile duct and cause jaundice, or block up the pancreatic duct and cause cholestasis. Certain infections do that. Not all the worms do that. And they may cause rectal prolapse. Again, some of these features are more specific to certain worms, like rectal prolapse. Typically, that occurs because of whipworm. Bowel obstruction or jaundice because of pancreatitis or blocking the pancreatic duct or the bile duct, that's more likely to be because of Ascaris. So there's some features that are more general, and then there are some specific to specific worms. Respiratory features are also common, and there's a lot of overlap between the features of acute respiratory infection and allergic respiratory disease and worm infestation. So wheezing and cough and respiratory distress and X-ray changes can also be seen with some of these worm infections that have a life cycle that involves the respiratory system, like Ascaris lumbricoides. And then there's other features. I'll show some pictures of the itchy migrating rash that you commonly see with cutaneous larva migrans, the infection caused by ankylostoma duodenalis. That is a very characteristic rash. And then other worms cause like a perianal itch, and other ones like Ascaris causes can cause an urticaria-like reaction in the skin, so with an IgE-related allergy. And then in terms of laboratory tests, we do laboratory tests often, and we often don't look for features of worm infection. But the most specific one, I suppose, is eosinophilia. So if you see a predominant eosinophilia on a blood film, then you've got to think that this child is quite likely to have a worm infection or a worm infestation. It doesn't mean that's the only cause of the child's illness, but they may also have that as a comorbidity, or it might actually be the cause of the child's illness if it fits that particular pattern of clinical features, especially if they've got respiratory symptoms. Then sometimes you can look for overrun parasites in the stool, and often on the blood film you'll see a hypochromic microcytic anemia, much more common with Necata americanus, the hookworm infestation, but it also can be seen with any of the worm infections. And as I said, many of these worm infestations are just asymptomatic. I mean, people have, millions of people in all countries have helminth infections, and for the vast majority they're asymptomatic. It's just you need to know the common symptoms that they present with. So that's the first slide that summarizes what the main things you need to know about worm infestations. The second one is I've tried to make a very simple summary about the life cycle issues and the treatment. So firstly, to know that the life cycles can be a human life cycle, just solely humans, or it can involve dogs or cats, or sometimes other animals, but dogs, cats, and humans are the most important hosts of these worms. And they may invade through the fecal oral route, and that's usually through eating contaminated food, or they may invade through skin penetration. And certain of these worms, like hookworm, invade through skin penetration more commonly, and some, like Ascaris, invade through eating contaminated food. The organs they affect, I've already talked about those. So small and large intestines, the skin, the lungs, and sometimes the brain. It's rare, but sometimes you can get cerebral infestation. But mostly the small and large intestines, the skin giving that cutaneous, larva, migrans, rash, the lungs giving wheeze and cough if they have a lung life cycle, if they migrate through the alveoli into the airways, causing wheeze and cough, and occasionally, as I said, the brain. The treatment in general is anti-helminth drugs. And I'll talk a bit about them, but you just need to know about albendazole, mebendazole, and ivermectin. They're the three that are the most useful anti-helminth medications. There's a couple of others that are uncommonly used and not as easily available, but know about albendazole, mebendazole, and ivermectin. Now, the third slide that summarizes everything about this talk really just summarizes the 6 types of worms we're going to talk about, and about what the host is, what the route of ingestion or route of invasion is, the organs that are affected, and the treatment. And so we'll talk first about Ascaris lumbricoides, which just has a human host, and also has a human host, but has a life cycle that involves maturation of the eggs outside the human in the soil. It's fecal oral spread, so it doesn't invade through the skin, but fecal oral spread. It involves it's a worm that involves the intestines and the airways and the lungs, and from that you can tell it's a migrating worm that goes throughout the body until it rests in the small intestine. And the treatment is albendazole and mebendazole. The next one is probably the most common, which is hookworm, Necata americanus. Necata americanus is the most common hookworm in PNG. In some other countries it's Necata duodenale, but in PNG it's Necata americanus. The human is the only host again of hookworm, but different to Ascaris, it invades through skin penetration, usually of children, usually through walking on bare feet, walking on ground with bare feet. And it involves the intestines only. It doesn't have a cycle that goes throughout the lungs or any other organs, but involves the intestines. And children then get blood loss, very microscopic blood loss, and then anaemia, usually iron deficiency anemia. And the treatment again is albendazole and mebendazole. The next one, the third one, is cutaneous larva migrans, and that's caused by Ankylostoma brasilense. And the host for that that worm is the dog or the cat, and of course then it infects the human. And it, like hookworm, it invades through skin penetration, and you get skin irritation, and you get this serpiginous migratory geographic rash. I'll show you some pictures of that. And the treatment again is albendazole and ivermectin in this case. And this causes cutaneous larva migrans really causes problems only because of this skin irritation and the very itchy rash that it gives people. The fourth worm is whipworm, which I mentioned before, Trichuris trichiura, and that has a host that's only humans. It involves fecal oral spread, eating contaminated food, and it also just involves the bowel, so the large intestines particularly. And because it has such a burden of worms, it can cause, and involving the large intestine, it can cause rectal prolapse. That's the characteristic feature. If you see a child with rectal prolapse, then they're likely to have malnutrition, and they're likely to have Trichuris trichiura infection. And the treatment is mebendazole, but you have to treat for a bit longer, for 3 days with mebendazole, typically, to treat that. The fourth and fifth one is Strongyloides infections. And there's two types that are important. One is Strongyloides stercoralis, which is the most common Strongyloides infection across the world. And dogs and humans are the hosts for that infection. That also invades through skin penetration, and it involves the skin, the intestines, and then migrates throughout the body, in the lungs, sometimes the brain, sometimes causing a severe sepsis, and it also responds to albendazole. And then the last one, the other Strongyloides that's important in PNG, is Strongyloides fulaborni, and that is a worm infestation that's not commonly been described in other countries, but it has been described in PNG, and it causes what's called a swollen belly syndrome. So many of these children present in young infancy, in early infancy, with a very swollen abdomen. Now, there's lots of things that can cause a swollen abdomen, but Strongyloides fulaborni is one that does that. And it unlike other worm infestations, it is transmitted vertically from the mother to the fetus. And again, albendazole will treat that. So it's fairly easy to, I think, identify the clinical features of these worm infestations. And it's also easy to empirically treat in case a child might have these worm infestations. So just the main message is, don't forget worm infestations, but try to consider whether or not this child that you're treating might actually have a worm infestation, as well as, or as the sole cause of their clinical features. So I'm just going to talk a bit about Ascaris lumbricoides and just try to describe these 6 worms in a little bit more detail. I don't think you need to know this in that much detail, but it just gives you an idea about the differences between these worms and how they manifest differently clinically, and also the different life cycles. So Ascaris has a life cycle that only involves humans, remember, and the worms live in the small intestine, where they lay up to 200,000 eggs a day. They're then excreted into the stool, and then they pass onto the ground if there's contamination of the toileting facilities, or if people defecate on the ground, and the unfertilized eggs, which are generally excreted, they then germinate or embryonate in the soil, and it's only after that they may infect vegetables or some other plants that are then maybe eaten by the next unsuspecting human, or small children might contaminate their hands with infected soil and put that in their mouth, and then the life cycle starts again, where the worms are ingested into the small intestine. They then pass through the small intestine, through the mucosa of the duodenum. They get into the circulation. They then, from the circulation, they're going through the venous circulation back to the heart, back to the right side of the heart, through the pulmonary artery, into the pulmonary alveoli. And then, because they're a bit stuck, because the blood vessels are fairly small, they migrate through the alveolar capillaries into the alveoli, then into the bronchi, and then are coughed up. They may cause wheeze or cough in the lungs. They're coughed up into the mouth and then swallowed again to the small intestine. So that's the life cycle of the of Ascaris lumbricoides, and that's why they cause the manifestations they do. So it's a large roundworm. They're up to 30 centimeters long, like nearly a foot long, and they're migratory. Obviously, they migrate around organs. They may cause, on their way, on their travels, mechanical obstruction to the small bowel. They sometimes cause intussusception, and this is the worm that sometimes during their migratory phase, they may obstruct the bile ducts and cause cholangitis, or obstruct the pancreatic ducts and cause pancreatitis. And so if you see a child with these features, then just think there could be lots of other reasons why a child might get jaundice, cholestatic jaundice, or pancreatitis, but just think of worm infestation. They may cause laryngeal obstruction when they're coughed up into the airway. Sometimes that can cause airway obstruction temporarily, and the child has trouble coughing it out. And they may, while they're in the lungs, cause an allergic reaction called Loeffler's syndrome, which is like a IgE-mediated reaction, a bit like urticaria, a bit like an allergic response that one sees in asthma with wheeze, and cause bronchospasm. So again, it's the constellation of these clinical features that you sometimes can put together and say, well, this looks like a child who might have worm infestation. They may cause malnutrition and, again, a swollen belly and edema. And so they're the features usually of Ascaris. Loeffler's syndrome was first described in 1932. It's a very old syndrome, and people recognise that that in patients who are coming either asymptomatically or were suspected of having tuberculosis, had some X-ray changes, usually peripheral opacification and eosinophilia, and they had wheeze. And that was the clinical features they first described as Loeffler's syndrome. And the interesting thing to me is that many of these patients were thought to have pulmonary TB, and actually they had Ascaris worm infestation. These are the earliest clinical features of people who had Loeffler's syndrome. You can see the patchy opacification that we might say, oh, it looks like consolidation. But if you do serial X-rays, the patchy changes appear and then they disappear. And that's because they're the changes of worms that then are coughed up into the more proximal airways and coughed out and then swallowed. And so Loeffler's syndrome is a sort of transient or migrating radiographic changes, as well as migrating worms throughout the body. Yeah. The risk factors for Ascaris, well, if you really poor sanitation, isn't it? And young children are very affected because they are likely to put their hands in soil and they put their hands to their mouth. If fruit and vegetables are not cooked properly, they're not peeled and they're not washed in clean water before they're eaten, then at high risk of having vegetables contaminated with the eggs of Ascaris. You can see the eggs in the stool, and about 10 to 30% of people with Ascaris have eosinophilia. They may have those X-ray changes I talked about. And remember, I said that albendazole. So you can treat most of these worms by albendazole and mebendazole, not all of them, but most of them. And so using both of those, this is a picture of the eggs in the stool. And these are the worms. Remember, I said they're up to 30 centimeters long. They can be quite extensive, and you can sometimes see these worms in the stool, but often coughed out by a patient. The next one is hookworm, and hookworm is so common. Maybe more than half the child population are affected in PNG with hookworm. There are studies that have been done in mostly rural areas. It may be a little bit less these days, but probably still about half the population. Mostly it's due to Nacata americanus, as I said, this other one, Ankylostoma duodenale, which is a common cause of hookworm in other countries, is not so much found in PNG. They're very tiny worms, right? They're only 500 microns long, so they're the larva penetrate through the skin. They can penetrate through the pores in the skin, and especially in the heel, they go through from the skin, they go through the lymphatics and the venules, get into tissue, and then are taken up by the lymphatics, again get into the right heart and through the pulmonary capillaries into the alveoli, the airways, the trachea, the pharynx, and then are swallowed. They don't cause so much in terms of respiratory symptoms, but they're more commonly cause small intestinal features, because the worms hook onto the mucosa of the bowel, and they just remove just the tiniest amount of blood. And if they do that every day, if you've got thousands of worms in your bowel and they're removing the tiniest amount of blood, then over weeks and months, you'll become iron deficient, because whenever a small amount of blood is removed, then iron is removed as well. This is the life cycle. The larva penetrate through the skin of a child who's not wearing shoes, and it goes up through the lymphatics and the venules into the veins, into the right side of the heart. Veins go, remember, they drain to the right side of the heart through the IVC, typically if it penetrates through the skin of the feet, the inferior vena cava, the right heart, the pulmonary arteries into the lungs. They're coughed up into the airway, into the mouth, and then they're swallowed and they lodge in the small intestine, and they then produce lots of eggs. And again, it's the lodging in the small intestine that causes most problems with hookworm, and it causes just microscopic blood loss. They're relatively small, unlike Ascaris that are large worms, and they can extract a tiny amount, just the tiniest amount of blood per day, just 0.05 mils, a really minuscule amount. But if you've got thousands of worms in your small intestine, then it's going to remove a lot of blood. These children with hookworm obviously present with anemia and poor growth, and sometimes they have a protein losing enteropathy. They may have hyperalbuminemia, abdominal pain, and diarrhoea. Remember the differential diagnosis of, for example, some other chronic inflammatory bowel disease like Crohn's disease, or typically Crohn's disease, maybe ulcerative colitis, but is hookworm infestation or other worm infestation. They may present with abdominal pain and diarrhea, and because so much energy is used up by these worms, then the children don't have enough energy for growth and brain development, and they become anemic, and so that also can cause a poor intellectual and cognitive development. They may also, the worms use up a lot of vitamin A, so they'll become vitamin A deficient as well. So the trouble with having lots of worms like this is that a lot of the energy, the food that children eat, gets consumed more or less by the worms. And the diagnosis is clinical and iron deficiency, and sometimes seeing the ova in the stool. The treatment is albendazole and mebendazole, and to replace the iron, so all these children are iron deplete, so giving iron supplementation, and vitamin C, that increases iron absorption, and vitamin A, because they're virtually all iron deficient, and making sure the child wears footwear and isn't prone to further infection. This is cutaneous larval migrans, which I said was caused by Ankylostoma brasilensis. And you can see the nature of the rash. You can see how it's raised, and it seems migratory. It looks like a worm is migrating through the skin, and that's exactly what's actually happening. And so the worm is migrating, and afterwards you're left with a scar. It's very itchy, and that's the main features that cutaneous larval migrans causes. This is the life cycle. Again, the larva, like with hookworm, penetrates through the skin. It goes through the, unlike the larva for hookworm, it doesn't go through the blood vessels into the heart and then the lungs and then go into the small intestine. It just migrates through the skin. That's the main problem that it causes. It migrates through the skin, causing this itchy rash. The host of cutaneous larval migrans is the dog, and usually the dog excretes the eggs in the feces, then they mature into the larva, and that penetrates through the skin of children that are not wearing shoes. This is the worm. If you look at a histopathological slide of this is the skin, the epidermis, and it just sits under the epidermis under the basement membrane of the skin. So it's the main feature is it's very itchy, and you can get the itch particularly on the feet and the toes, and you see the rash, the knees also, and the buttocks, and will be very itchy. That's the main feature. And again, treated with albendazole and ivermectin, just a single dose of ivermectin or albendazole, you usually get relief very, very quickly within 48 hours. And it takes a little while longer for those tracts to resolve, but they do within a week or so. The next worm is the whipworm. So we've talked about Ascaris lumbricoides, we talked about Nicata americanus, and we talked about Anti-helminthic brasilense. And the fourth one is Trichuris. Remember I said the classical feature of Trichuris is that it involves the large bowel, and it has so much involvement of the large bowel. The characteristic feature is bloody diarrhea. So it looks a lot like say colitis, and will cause anaemia because of blood loss, and also wasting because of the energy consumption. But the typical feature is rectal prolapse because it involves the very distal large bowel. So the life cycle again is only involving the human mostly, but it also can involve pigs. The adult worms live in the cecum or the colon or the rectum, and they're excreted in stool. The eggs mature in the soil and contaminate vegetables or gardens, and then those eggs are ingested by somebody else. So it's a spread of these worms. They hatch in the small intestine, and then just in the small intestine, and then go to the large intestine and cause bloody diarrhea, anemia, wasting, and rectal prolapse. The main thing to remember about Trichuris trichiura is that it involves the large intestine and involves a colitis, like hemorrhagic colitis, and rectal prolapse typically. This is the rectal prolapse caused by Trichuris trichiura, and it's part of the differential diagnosis of hemorrhagic colitis or dysentery, but typically with Trichuris trichiura, as opposed to Shigella, the other cause of dysentery, there's no fever. So the children don't look as toxic. They just have a severe rectal prolapse with bloody diarrhea. They're the main things to know. Rectal prolapse, iron deficiency, anemia because of bleeding, wasting because of energy consumption, eosinophilia because you've got a worm infestation. And if you look on direct fecal smear, then often you'll see the eggs. The treatment is mebendazole. That's ideal. Albendazole is not as good as mebendazole for Trichuris. So again, that's why we typically have used albendazole and mebendazole to treat worms in general. And then the last worm I wanted to talk about was Strongyloides. And remember I said there was two types, Strongyloides turcoralis, which is a relatively common type, and then Strongyloides culiborni, which is the type of worm that's vertically transmitted that typically only causes a swollen belly syndrome. But let's talk about Strongyloides turcoralis. It's an important worm in PNG. It has a sort of a long history, I think, and there have been studies done that show that about a quarter of all children are positive for Strongyloides, if you look. It has a complex life cycle, both an extrinsic life cycle, which means it can have a full life cycle out in the soil. It doesn't need a host, but it can also have a life cycle that involves dogs. Strongyloides is, again, one of those skin migratory worms. It'll travel to the intestines by the veins and the lymphatics, and it travels through the tissues as well. So it's a little bit unusual in that regard, but it can also have a complete life cycle out inside the intestine. So you can live with this worm for decades. And it came to light particularly in World War I veterans who got, as young men, they were soldiers, and they got the worm infestation when they were in the tropics. And often it was only when they were in their 80s or 70s that, because they became a bit immune suppressed because of old age, then the worm infestation became much worse. That was about 30 years ago. That was being seen relatively commonly in World War II veterans who'd been in the tropics. But it also can cause infection in immune-compromised patients, like with HIV. Often it's asymptomatic. Like a quarter of all children in PNG might have strongyloides, but from the vast majority of children, it's asymptomatic. As I said, most strongyloides infections are trivial unless you're immune compromised. It just causes an itchy migrating rash. And it sometimes causes, if you're immune compromised or if a child's quite unwell, it causes cough and wheeze. And again, abdominal pain, diarrhoea, steatorrhea. Malabsorption is pretty common with strongyloides and weight loss. And this causes like a lung infection as well, a bit like Ascaris causes Loeffler's syndrome. This can cause a generalized lung, like pneumonia, and it can, in a immune compromised person, it can cause what's like a hyperinfection syndrome involving many organs and general systemic inflammation with gastrointestinal features, sometimes because of the permeability of the gastrointestinal tract. You get a lot of gram-negative bacteria getting into the blood, and that can cause gram-negative septicemia, and it can cause serous effusions. So again, if you see a child with polyserositis, always think they might have strongyloides, or they might not. It can cause bacterial peritonitis because of perforation of the bowel, and it can cause these respiratory symptoms, a bit like Loeffler's syndrome, cough and wheeze and dyspnea and hemoptysis. And sometimes it can get into the brain and cause encephalitis. The diagnosis are the clinical features, and often I guess the most characteristic is fat malabsorption rather than gastrointestinal hemorrhage, unlike with Trichuris, where you get GI hemorrhage, and Hookworm, where you get GI hemorrhage. With strongyloides, you sometimes just get fat malabsorption. You can see the larva in the stool, in wet preparations of the stool. The treatment is albendazole. Again, 3 doses of albendazole. That those patients will be treated adequately. And then the last worm I want to just mention was strongyloides in infants. And again, this is a little bit different. It causes swollen belly syndrome. It's been described in Canabea in Gulf and in Madang, and it can be vertically transmitted from the mother through the placenta or the breast milk to the infant. And it just, if you see a young infant with a very swollen belly from a rural area, from a village, then just think about strongyloides fulabornae as a cause of that. Again, less common than Strongyloides stercoralis and less common than most of the other worms, but it's the characteristic feature is that it involves young infants, as opposed to most of the other worms that involve toddlers who can walk around and get either play with soil or have a worm larva penetrating through the skin. So this is a little bit different. Yeah, I wanted to just touch on the anti-helminth agents. I've talked about albendazole and mebendazole and ivermectin as the 3 most important ones. These were first described in the 1960s, and they're they were initially used as plant fungicides, so to remove fungus from plants, and then they were used in veterinary practice as anti-helminths, because obviously worm infestation is very common in veterinary practice. And then they were more refined for use in humans. So the earliest one that was used in humans was thiabendazole, and then mebendazole, and then albendazole. And they're the most important drugs. They are interesting drugs because they cause metabolic disruption of the parasites, like at a mitochondrial level, and they starve the parasite of energy production, so the parasite dies because of that. That's the reason why they work. It, of course, doesn't affect any human cells. That's most important. They're very safe drugs. They don't affect human mitochondria. They only affect parasite mitochondria, and they kill the adult worm in the gastrointestinal tract usually, and they're rarely absorbed. They're not systemically active. They virtually kill only the worm in the gastrointestinal tract. Albendazole is the most important, I suppose, anti-helminth. It's broad spectrum, and it kills like hookworm and Ascaris with a single dose, and then with a few doses with Strongyloides stercoralis. It's less effective against Trichuris, and as I said, mebendazole is better. So you have to have, if you're treating patient empirically for worms, then using albendazole, maybe single dose for 3 days, and mebendazole is better. And there are other anti-helminth agents, but often people think if they use metronidazole, that will treat helminths. No, it won't. That's an anti-protozoal agent. They will treat anaerobes and anaerobic bacteria and protozoa, but it won't treat helminths. So don't think that metronidazole, giving metronidazole or flagyl, will treat helminths. No, you've got to use albendazole or mebendazole or ivermectin to do that. I think you all know this about prevention being the most important thing, and there's a very strong connection, as I said, between these neglected tropical diseases and poverty. And it is a cycle. It's a cycle of poverty. So, if you think the poorest children have the poorest housing and no sanitation, and the poorest water supplies and no footwear and poor food preparation, then they're the conditions under which these worms circulate through communities and flourish. And then the worms themselves cause iron deficiency and anaemia and cognitive impairment and poor school performance if the children actually go to school, and micronutrient deficiency. And then they cause, clearly, these children have little prospects of getting good education and getting good jobs, and that further causes this cycle of poverty. So the World Health Organization is really determined to address these worm infestations, these helminth infections and other neglected tropical diseases. And we should be too, as paediatricians. We don't recognize them enough, and we don't treat them enough. We don't recognize them as causes of these infections, and we don't treat them enough. And also we don't think about them enough when we're thinking about public health programs. And there's been good public health programs of mass drug administration of albendazole, and public health programs encouraging children to wear footwear and improve housing, improve obviously water, sanitation, and hygiene and housing are most important for the prevention of these helminths. So what we've learned today, we've talked about Ascaris, we've talked about hookworm, human hookworm, we've talked about cutaneous larva migrans, we've talked about whipworm, Trichuris, and we talked about Strongyloides, so stercoralis and Fullerborne. That's all I wanted to talk about today. There are some other worms, but I think if you know about those 5 with the subgroup of Strongyloides stercoralis and Strongyloides Fullerborne, then you'll know about 90% of all the worms that infect children in PNG, and you'll have a good understanding of these worms. So that's all I want to say today. So thanks for your attention. I'm going to stop sharing my slides, and happy to answer any questions that you might have.